എനിക്ക് ഇത് 4 പൂവാക്കാടെ ഇതുപോലെ തന്നെ ചെയ്യും. വട്ടം വട്ടത്തിൽ വരയ്ക്കുക എല്ലായിടവും. അതിന്റെ നടുക്ക് യെല്ലോ ആക്കാം. No, this is my teacher. You want to see? വാഷ് ചെയ്തിട്ട് വേണം. അന്ന് ആ കപ്പിന്റെ അകത്ത് വെള്ളം എടുത്തുണ്ടോ? നോ പ്രോബ്ലം. ഒന്ന് മൂത്രമൊഴിച്ചെന്ന് പറയാം.
Once the session starts, they'll be muting others, no?
But Mariam, your audio is on. Stage 93.
Dr. David, should we start the initial part or should we wait till sir come into the discussion?
Rakesh can decide.
Yeah, I think we can start slightly. I think he said he'll be there in 5 minutes, no?
Yeah, that will be good.
Yeah. You won't miss much.
Can I start so that the more time we can get for discussion?
Yeah, I think we should because it's already 8:34.
Yeah, more than 100 join. So shall I start?
Yes.
Dr. Rakesh,
Yeah, please.
So, good evening all. Good evening, the esteemed speakers, senior dermatologists and colleagues and postgraduate students joining us today. So on behalf of Online Academy of IDVL Kerala, it gives me an immense pleasure to welcome you all to DermAge1, the first session of our 6-part academic series focusing on neonatal dermatology, a phase that is clinically challenging to all of us. We are privileged to have an eminent panel of experts with extensive clinical experience and academic interest. The session will be ably moderated by Dr. Rakesh SV, whose leadership and academic contributions need no introduction. I would like to express my sincere gratitude to IIDVL Kerala, especially to the President, Dr. David Pudukkadin, and the Secretary, Dr. Joanne Felicita Sampson, for their unwavering commitment and encouraging support in making the session possible. And with this, I formally invite Dr. David Pudukkadin for the presidential address. Thank you all.
Respected seniors, dear colleagues, distinguished faculty, good evening. As President of IIDVL Kerala, it gives me great pleasure to invite you all to DermAge1, an academic feast dedicated to neonatal dermatosis. This CME is the first of 6-part series dedicated to different age groups. And this session has been thoughtfully curated by IDVL Kerala Online Academy, headed by Dr. Priya Pradap and Dr. Nimita, and is rooted in real clinical cases and is focused on practical day-to-day decision making. We are privileged to have eminent faculty panel led by our immediate past president, Dr. Rakesh, supported by nationally respected academicians. Their collective experience will translate evidence into practice and offer clear, usable take-home messages for routine care. I strongly urge all members to join, participate actively, and enrich the discussion. I am confident this program will be highly useful, educative, and clinically relevant. Let us come together to learn, share, and make DermAge1 a meaningful academic success. Thank you. Jai Hind, Jai IIDVL. I would like to hand over the mic to Dr. Rakesh to continue the proceedings. Thank you.
Okay, shall I start the presentation? Okay. Oh, it's so cute. Okay, is my PowerPoint visible?
Yes, sir.
It is visible, sir.
So,
Yeah,
yeah,
visible.
and I'm audible, right? Okay.
Yeah.
So,
Yes.
good evening and warm wishes. So it's indeed, I would like to first initially congratulate Dr. David on having this thought process of a series of academic series of dermatoses according to the age. And I think I'm sure it is going to be a great program all throughout. And as an initial batsman, it gives me immense pleasure, gratitude, and indeed honored to be able to kickstart um, uh, this program. So I don't want to waste much time. So we have just 1 hour and we'll try to finish off as much as possible. So today we are starting with the neonatal dermatology. So first let me introduce myself. Many of you must know I'm Dr. Rakesh. I work at Astor Mims Calicut. And then we have a very distinguished pediatric dermatologists, three of them, Dr. Ram Kumar from KKCT at Chennai. No, this slide is not proceeding. One second. Dr. Neetu Bari from AIMS, she's additional professor at New Delhi. And then you have a very young blood, Dr. Erin Matthew, who is working at AIMS Partner. She's a Kerala IDVL member also. And first of all, I would like to welcome all three of you to this discussion. So before I begin, there's just one basic rule for the panel discussion. We will have I would expect you to give short and precise answers so that we can finish most of the slides. We have around 10 cases. It will be a case scenario based discussion, which I'm sure will be beneficial rather than going on another method. So here we go. So today we'll be speaking on small patients with big differentials, small patients who cannot speak, and history which we have to take elicit, and sometimes which comes after the clinical diagnosis. Many of the times, most of the conditions in neonatal dermatology, as we all know, are physiological, and we have to reassure. But then certain benign-looking lesions might also turn out to be leading to something more serious disease. And it is here we to identify the benign and the serious ones. So first of all, I will go with this particular neonate who was born, who presented on the second day of the life with a symmetrical, violaceous, or erythematous reticular mottling of the limbs, more prominent on the cold exposure, and it was resolving partially on warming. Otherwise, the baby is healthy and feeding well and nearby. So my first question to Dr. Ramkumar. So I'm sure everyone here knows has identified the condition, that is cutis marmorata. So is this physiological or pathological, Dr. Ramkumar?
Cutis marmorata is a very common thing, in our
You're not much
neonatology.
audible. Can you make it? Is it my problem or general?
I don't know.
Not audible, sir. Ramkumar sir is not audible.
Yeah. Hello? Hello? Can you hear me?
So
We
your
we
voice
can
is
see
little low.
Little
feeble.
low.
Are you on a microphone or a laptop?
Laptop it is.
Can you
Laptop,
just
sir.
check the mic volume?
1 minute, sir. 1 minute. Mic volume is maximum it is. Can you hear me now?
Still feeble.
Well, you're audible, but very feeble. Voice is very feeble.
Maybe you rejoin, sir. You join once again, so that might help.
I think I'll just shift the question to Dr. Neetu Bari while Dr. Ramkumar. So, Dr. Neetu, tell us, is cutis marmorata physiological or is it pathological?
Right, sir. Thank you, sir. So in neonate, because today we are discussing neonatal dermatology, and even in infants, cutis marmorata is physiological in most of the cases, sir. I think more than 98-99% of the cases we can see that this is a normal phenomena to temperature change, because these vessels are cold sensitive. So whenever there is a temperature change and child is exposed to a colder environment, and on rewarming they disappear. So only
So,
reassurance is required in most of the cases.
okay. So now, would you investigate any red flags which will prompt you to do an investigation or send any investigation? And what investigation, if at all, you want to send, would you send?
Right. So in neonates, cutis marmorata telangiectasia congenita is a differential. And there we see it is also present at birth, but we can see some surface changes as well. So there may be areas of ulceration, distinct atrophy may be seen. There may be limb hypoplasia or aplasia, and then the history of persistent lesion, maybe even little worsening with time. So that, and mostly unilateral compared to the bilateral presentation of cutis marmorata. If that is there, then we can do Doppler ultrasound to look for the vascular anomalies.
Okay. Anything, because I remember reading somewhere, is it anyway related to hypothyroidism or anything? Is there any evidence on an underlying hypothyroidism leading to
Not that I
cutis?
am aware of. We all we do is reassurance whenever we see a patient of cutis
So
marmorata.
99% it is
Yes.
basically a physiological vasomotor instability,
Right.
and very rarely, if there is any asymmetry, ulceration, or persistent pattern, you would think of the
Vascular
cutis
malformation of
telangiectasia.
cutis marmorata. Yes.
Okay, thank you so much. I think we'll go to the next case because it's a
I
very common
think,
thing.
Sir, like,
Any
I'd like to
doctor,
tell you.
Irene, do you want to add something apart from?
sir, you were asking about hypothyroidism, sir. Like, if it
Yes.
is persistent, usually
Yeah.
if it disappears on rewarming, not localized like CMTC, I asked them to watch out till the second and third, first and second vaccination dates. So, if it is disappearing in 2 to 3 months, it is usually fine. But if it persists, I do check for hypothyroidism and sometimes downs. These are the only two associations, but not in a neonate. First 28 days, we'll take it as totally normal.
Right. Okay. Okay, now we go to the case two, that basically dealing with the pustular lesions which are present at birth. So this neonate presented multiple superficial pustular lesions at the trunk and limbs at birth. It is present at birth. Infant is afebrile, feeding well, and with there is no maternal history of any infection. So what is the first thing you would think of in this particular baby, Dr. Irene?
Sir, first thing I would do is check if the baby's the tone is good, not meconium stained, and normal birth weight. So whether like high risk baby or a low risk baby. Then I'd examine the baby if it's active, feeding, passing urine and stools. If the baby is entirely well, I'll go for the physiological causes. And I would, since it is present at birth, and I think hands and feet were involved. So I would go more towards transient neonatal pustula melanosis. There is no melanosis at present, but probably it may evolve. But sometimes the neonatal pustula melanosis and erythema toxica neonatorum can overlap little bit clinically. So I would just group it as physiological pustulosis. If all there are no red flags at all, like baseline not a high risk baby, examination is entirely well, and full maternal history, no PROM, no prolonged labor, lochia is fine. So mother is febrile. So if there are no red flags at all, I would not investigate. I just tell the natural
Yes.
course. Yeah.
I mean, what would you tell the parents or the
Yeah,
parents or
I
the
would tell the parents
pediatricians?
that it will last for, usually I say 7 to 10 days, like the upper limit, so that they don't panic. In 7 to 10 days, a few lesions more may come and then it may disappear. So I
And that
cover
it
for
can leave, it may leave pigmentation. Maybe
pigmentation, but everything will disappear after few months. That's
okay.
usually what
Now,
I tell.
now the same baby starts to get fever and poor feeding. I was saying, uh, and what are the other conditions which you would think of? The fever, the pustulation seems to be more florid, and the child is exhibiting poor feeding behavior. Anything else you would think of?
Sir, I would think of all infections. Mostly, I would focus on the bacterial ones and the viral ones.
Okay,
So,
so tell me what are the
yeah.
ones which you do
So,
think of?
bacterial ones are like it could be any transplacental or at labor infection. So, I would look at the mother and I would immediately send a gram stain from the pustules and take culture immediately. And along with that, sepsis screen basic protocol will be sent by the pediatrician with the blood cultures also. And looking at the neurology, and if you are suspecting it or the organism, sometimes a CSF tap that usually let the pediatrician decide. And lochia cultures or even maternal cultures would help. So, empirical antibiotics, we would cover streptococcus and listeria probably, if otherwise there are no specific high risk factors. Um, then viral ones, I would definitely ask the mother if there is any contact with varicella, mother has any skin lesions, any genital lesions currently, or even very old herpes lesions. So if we are suspecting, and I would immediately do a Zang smear, and usually in our center we have PCR, so I would send a PCR immediately. And then I would follow up with CSF PCR also if there's a strong clinical suspicion. And empirically start acyclovir if you are suspecting it. So these are the things I focus on. If the baby
So
is not,
you will do a gram stain,
I'll
you
do
will
a
do
gram
a Zang
stain.
smear.
I'll do a Zang smear. HSV, I prefer HSV PCR here because I mean more sensitive. But then in a setting where it is not possible, I would do a Zang smear. I would do local cultures for bacteria and blood cultures and plus or minus CSF examination.
Any role for KOH in this child? I mean, if
In a
check,
well child, sir, I in a
you would.
term baby normal birth weight, I wouldn't think of candidiasis,
But if the
congenital
child has
candidiasis
oral
immediately.
lesions, probably you would have thought
Yeah,
of
with palmar
this.
lesions, oral lesions, mother has some features, and especially preterm babies, and with some PROM and all that, I would think of candidiasis. Then I would go with KOH and empirically add azoles to the regimen.
Okay, I think you have covered most of them. I don't think we need to discuss more on this. Dr. Ramkumar,
Yeah. Hello.
you're still your audio is. Have you checked your monitor? I mean, the laptop.
I don't know. This is what how much I am not able to find out what is the problem here.
I think you just
Again,
go on to Zoom. Just David, can you just guide him? Zoom, when you go to the Zoom audio setting, then you can check your microphone and the phone. Then you can know whether it is a hardware issue or a software issue.
can you hear me now?
Sir, we can
Very
all
few.
hear him, sir. We can understand what he's saying. If you
Okay,
are,
I think you just have to.
I think sir
Uh,
can speak closer, maybe. I mean,
yeah,
still
you can
audible.
just speak a bit
Yeah,
louder and closer.
yeah, yeah.
Okay,
So
so
I think
then
it
we'll
is.
go to the. So now we have a different. I mean, child. Let us imagine that the pustular lesions had appeared on the third day. what is the diagnosis? So thinking of transient neonatal pustular melanosis. At this third day, what did you think of, Dr. Ram Kumar?
See, transient thing, no, because most of the time how we will pick it up is by seeing the pigmentation which comes later on, and especially in have a child on day 3 or 4, you will be more interested in ruling out any, even a pediatrician, you have to be always keep a pediatrician in the loop. You'll be more interested in ruling out any systemic condition. So the commonest, when you have a generalized pustule like that, see the first photograph which you had shown earlier had erythema around the pustules. The first
Yeah.
photograph which you had shown,
Yeah,
last
yeah.
this one also. So you see erythema around the pustule, you will always keep erythema toxicum neonatum as the first differential diagnosis. Transient neonatal pustulosis, most often time, I do not know about government hospital. In private setup, the child is cleaned as soon as that after the delivery, the child is cleaned, and most of the transient neonatal pustules are wiped out. And what you won't see that typical vesicles without erythema, all that. So as Dr. Irene said, we have to keep an open mind, because most important thing in neonate is we may miss gram-negative and streptococcal infection. Streptococcal infection can involve the internal organs also, unlike in older child. A non-neonate, I mean, we can treat it on our own. So neonate, always we should keep a pediatrician under the loop. And the most important thing is the palms and soles, which are very characteristically can be involved in candidiasis. And herpes can is not that common in our Indian setup, probably, I think, in compared to the Western countries. But still, even a single vesicle can be due to herpes also, can be a single vesicle also, depending upon the internal condition. The most important thing is the internal, what is the internal condition of the baby, that we should not assess. We should ask the pediatrician to assess, and the assessment should be on day by day basis. And I will go about like that only, not
Yeah.
not to point out a particular
Okay.
diagnosis.
So would you do a gram stain and a KOH in all cases? I mean, the
Yes,
gram stain and
gram stain
Zank
and
smear
culture, gram stain and culture, always a
culture.
gram stain and culture, not just culture, because sometimes you
Okay.
can miss out in culture, you can get in gram stain, always, always. And I won't rely on Zank all the time, even if Zank can be sometimes
Mm.
negative, because Zank is sensitive, but not I'm sorry, Zank
Yeah.
is specific,
It
not very sensitive.
not sensitive at all.
Yeah.
Okay.
I won't because all this we have to discuss with the pediatrician. Otherwise, and everything. And once it is herpes simplex, the treatment should be by the pediatrician, because the diagnosis, you have 3 weeks of treatment, and 40% of the children will have the CNS will be affected. I mean, it's not the thing that is to be treated by us as a solo.
Okay.
Rakesh
Thank you.
sir,
Thank you.
if I can add,
Anyone want to add something here?
Rakesh sir, if I can add, for the first case, I also thought of erythema toxicum neonatorum first. Though the
Yeah.
onset is little earlier,
Yeah.
but the erythema was very prominent. And
Yeah.
also, I just wanted to add that one or two patient, not very frequently, we have also seen of congenital pustular psoriasis. So since you said your child is febrile, not feeding well, so that as a rare or differential we can keep in addition.
Uh,
Commoner are infections, so that we should not miss.
but usually the child will be toxic when if you're thinking of pustular
Pustular.
psoriasis, right?
Yes, sir. Only when you said if the child also has fever and is not
Yeah.
feeding well,
Yeah. That
then
is a differential I think you have to keep
okay.
in mind. Thank you so much. Thank you.
Right.
Okay, I think we'll go on to the next case. I think Dr. Ram Kumar can take that. He has not taken up the case initially. So this is a neonate who was noted to have a single tense clear bulle over the elbow at birth. Just one single tense clear bulle over the elbow at birth. There's no other lesions. So what are the different diagnoses you will keep in mind, and what are the other differentials? What are the most likely diagnoses? The child is afebrile, perfectly doing fine, feeding well, doing great.
The blister is very clear. It seems to be very clear from what I see in
Very
that
clear and
picture.
non-erythematous. No
And
erythematous.
yeah, and the skin does not appear to be thick or anything, thick or rubbery or something like that. It looks like surrounding skin is absolutely normal. Supposing
Mhm.
there is, if I see a similar rash in the, the see, once again, I would depend upon the inner condition of the child, whether the condition, the sensorium, everything is normal. That I will always keep in mind and not depend only upon the morphology. If the child is otherwise normal, I would probably take it as some injury or something. The same lesion, suppose I see in the groin, it may develop pustule also. It can develop a bullous sympathic also, the groin. Especially in the
Exactly.
first 2-3 weeks, neonatal pustulosis on the groin area is very common, and pediatricians, routine office pediatricians, they know better than the in-house pediatricians. They will pick it up easily. So I won't give a clear diagnosis. Wait for some time. Maybe some frictional, or I do not know. I would wait for the time for the diagnosis. I won't directly pierce it and do culture and all.
Okay. Dr. Nita, hello.
Yes, sir.
Would you like to comment on anything on this?
Yes, I agree, sir. This is very bland looking blister. There is no erythema or sign of inflammation, and it is in very young child. So mostly traumatic at this point of time, and keep and watch if he's developing a new lesion anywhere else.
I think we have to convince the pediatricians that it is not necessary that we always have a diagnosis. It is sometimes you just have to wait and watch also. Can we think of, because this particular child, I was thinking of two things. One was a sucking blister. Sucking
Yes.
blister, the child
Elbow.
elbow, the elbow and the hands are the most common side due to constant suction of the intra and friction also due to handling by this thing. These are the two things I had kept in mind in the discussion.
So
Um,
may I add 2 points?
yeah,
One is that, sir, I had a similar baby like few years back with one blunt blister with subtle desquamation of the palms. And that child came out to be congenital syphilis. So usually, even when I see one, I
oh,
do a
great.
meticulous examination, and obviously I watch out for other features and new blisters. But if the mother has a late pregnancy VDRL or TPHA negative, then I am relatively calm. But there are plenty of pregnant women who have a very early first trimester VDRL and late, which is negative, and later they are positive. So, like in a neonate, because many lesions may not be florid to begin with, even a single bulla, I just keep syphilis in mind. Uh, Sometimes the skin can be a little subtle and very unusually subepidermal blistering immunobullous disorders in children. Like mostly the mother may have antibodies and clinical lesions, but very rarely mother may not have lesions. So if the mother has a subepidermal blistering disorder, the same thing can happen in the child also. But then only one relatively bland, nothing happening further, I wouldn't go there.
So mostly you would just wait and
I would wait.
wait
I'll
for the
check the
progress.
mother's VDRL, just wait to see if new are coming.
Bulla simpatico is not something, a single bulle we
Yeah,
wouldn't think of
bland
right now.
looking.
Bland looking,
And
no.
it
I
will
mean, bullous
break up in the
empatigo
long
also
term.
it's on non-erythematous background mostly, but still we would
Yeah,
just wait and see, right?
yeah.
It
Uh,
will be more, yeah. And another one thing we can keep is sometimes if this sort of things come again and again and months together in the same site, that sometimes mastocytosis can come like a single
Yes,
lesion.
yeah,
mastocytoma.
If it comes
yeah. Actually,
repeatedly,
in fact, I had, but
not in the newborn,
usually it
repeatedly.
goes on an infiltrated bull,
Yeah,
infiltrated
yeah,
plaque,
yeah.
and also,
Ah, yeah,
and
yeah.
there's an urticarial edematous background
Background will be
over
there.
which the bulla is surmounted.
Yeah, yeah.
Yeah. Okay. So I think we'll go to the next case. So this is a very classical presentation of epidermolysis bullosa. So now you have this child has multiple hemorrhagic bullae, erosion, sites of multiple trauma, milia formation of the face. This child would have been a bit later. I just put it for the representative state and acral blistering also. So can you see the hemorrhagic bullae and the milia formation also? So now how do you differentiate? So I think one of you can tell me, Dr. Nita, would you like to take that? How would you differentiate? So, because you are suspecting epidermolysis, any other mechanobullous or immunobullous disorders you would like to think of in this particular baby? And then let us go on to the next step.
Sir, most of the time the diagnosis is clinical, sir. As you said, this is slightly older child. Otherwise, in neonate, we mostly see the denuded skin on the lower leg. which is at the time of the delivery or intrauterine, there is some damage. And then we see blister on the toes and maybe few nail loss, anonychia also. But I think there may be some areas of scarring, but mostly the diagnosis is clinical at this point of time. EB matrix, we know in infants it is not very
Okay.
successful or not very pathognomic, because pathognomic signs and symptoms do not develop by then. And genetic analysis, if possible. If there are other signs, so we also look at the oral cavity. If there is, if there are oral erosion or a smooth tongue, so loss of papilla, that also gives us a hint. The parents giving that history of blistering at the site of trauma or at the site of rubbing also gives a little clue about the diagnosis. And then, if the parents are affording, we also ask for genetic testing, sir. In if there is laryngeal involvement, so we look for all signs and symptoms, and then the diagnosis is primarily clinical. Only place where we sometimes have difficulty is to differentiating it from, that is true for EB simplex variant. Sometimes we have difficulty differentiating it from CBDC, which is chronic bullous disease of childhood. Sometimes that situation comes, otherwise most of the time the diagnosis is clear.
But neonate is not a very common age for CBDC. So I
Yes,
think
sir. Yeah.
That comes little later, yes, sir.
little later. Okay. Dr. Iron, can you just tell us why, if you have to clinically, I mean, you would like to reassure the patient, I mean, you'd like to give a prognostic, we might be having a prognostic discussion with the pediatrician or this thing. So what are the things which you will keep in mind? What points will you think, make you think that, okay, this is EBS. Okay, this could be a junctional or an EBD. So let us just differentiate between EBS and EBD. What are the clinical
Yeah.
points which should make you think in favor of EBS? What are the points which will make you think more in favor of? I'm talking about not about this child, probably a neonate, just to have a
In a
ref
neonate. Yeah, yes, sir.
in a neonate.
Okay, sir. In a neonate, before, while we are discussing subtypes with the pediatrician and the parent, I would definitely take an anticipatory bail, saying that it's just a guess and it can change drastically in a few weeks. So, as
Excellent.
ma'am has already listed out the specific signs that I look for. One is laryngeal involvement, junctional. That is a clear clue. Deep papillated or a smooth tongue is recessive dystrophic, poor prognosis. So
Right.
that is one situation where I always confidently say poor prognosis to the parents, because they really want an idea of what is going to happen. Third things are, some, if at all, very rarely they develop pyloric atresia. So that again goes to junctional. And sir, even though you asked only about dystrophic and simplex, junctional is pretty common in all the centers I worked. So
Okay.
scalp involvement, extensive scalp involvement somehow, and back involvement, usually junctional. I don't know the sensitivity or specificity, is just a clinical observation. So more than the subtypes, sir, I would, in the neonate, I'm concerned more about the severity. And if it's the smooth depapillated trunk, I know it is going for a little severity, but I usually tell the parents ki we will have to wait and see. If it is very focal or mild or maybe generalized intermediate group clinically, I would say that it will definitely improve. If it is very severe at birth, then it, many kids have improved significantly, but I would say that because of the complications in the neonatal period, they do definitely have a lot of issues. So there I would give a guarded prognosis. But if it is not very severe, I would say it definitely improves with age. Like the fragility improves after the first year. But it would be I would give a very guarded prognosis. Mostly teaching them how to manage the child at home and getting the child out of the hospital to prevent infections is usually my priority.
Okay. Dr. Ramkumar, may I ask you what at what point of the time would you start investigating the patient? Would you straight away go for a biopsy, or would you wait? And what are the investigations you would do in a neonate?
I will never go for an investigation immediately. And all this, see, the child, suppose the child is delivered by cesarean, you will not know, the symptoms may be very mild. Only if the child is delivered by vagina, you will see all those symptoms, and it may be surreptitious. It may be they look very normal. I missed one pyloric stenosis that the pediatrician had done. He was asking me. He had to do a procedure for a pyloric obstruction. The child was looking absolutely normal, and after 2 weeks the child developed few erosions. Meanwhile, I was giving them a guarded diagnosis, could be this or that, and finally we got a diagnosis of pyloric stenosis, that is this plectin deficiency. So never go by the clinical features, say mild, moderate, severe. So because most of the child, if the child is delivered by cesarean, you may not have trauma and you may not have any of the features. So all the features develop only with the trauma. So the moment you suspect epidermis bullosa, we should tell them how to handle the child carefully. There is a good protocol for that. That's the first point I want to make. Second point is, irrespective of whether it is a simplex or junctional or dystrophic, if once the maximum mortality is same in the neonatal period, the mortality is same whether it is a simplex, because secondary infection is very much common in the children. So once it crosses that first 1 month, all your predictions like junctional or dystrophic, if at all it has got any validity, it will work. So in the first 1 month, you, irrespective of what is the problem, the child has to cross the neonatal phase. Even it is simplex also, we should not give a diagnosis. We should not tell, we should not be less cautious in treating the internal issues like fluids and other things also. So whether irrespective of the type of epidermis bullosa, the prognosis is same in the neonatal period. And as Dr. Irene said, oral cavity involvement and nail, periangle region involvement, and then all these things are pointers. But honestly speaking, earlier, if I suspected junctional or dystrophic, I was doing that immunomapping and all. But nowadays, I have shifted to genetic investigations because they test more genes than our immunomap.
Now, how will your Dr. Neeta, how will your consultation response record as for management? What will you write?
Sir,
I mean, apart
yes, sir.
the
Yes.
management part, like what are the things you would recommend for the care of the skin in this child?
Right, sir. So management is still mostly supportive, sir. And because as I said, in the neonate period, we see large area of denuded skin on the lower leg in many of these children. So a proper dressing to prevent the secondary infection is our primary aim. So if they can, and to use non-adhesive dressing to explain to explain it to them that using non-adhesive dressing, using gauze instead of micropore, and if possible use better dressings. Then if the nutrition part also, we need to counsel them that breastfeeding if possible should be continued, otherwise a proper amount of nutrition should go as per the direction of pediatric team. Vaccination should be continued as required, they should not be abandoned. And the trauma should be minimized, so that counseling is also important. Sometimes the child develop blisters between the fingers, so that kind of dressing sometimes we advise them, because we want to avoid mitten deformity as much as possible. So counseling probably at this point of time. Genetic counseling is too early, maybe in the subsequent visit we do, sir, that it is a genetic condition and the diagnosis we offer them, but majority of the patient coming to us belong to the poor strata. So mostly clinical diagnosis with supportive management.
Okay.
Uh,
Okay. Thank
sir,
you so
may,
much. Thank you
may
so
I
much.
add
Yeah,
two
please.
points? Sir, one is that as Ram sir was rightly pointing out, the surviving the infection, risk of infection is the most important. So in my case, because there have been few issues, I tend to send genetic investigation early. Because not for the child per se, but sometimes the child expires unexpectedly, very much more rapidly than we expect, and then the parents never have any genetic diagnosis. So for the child, so in the next child they have to go in blindly without the possibility of antenatal testing. So since now competing labs whole exome sequencing is pretty cheap, I make sure at least store a sample for genetic testing. That is one of my first response. And in
So
care,
what exactly would you ask for? Can you just
I would go for whole
for
exome sequencing,
delegates?
sir. From the child, I would collect 2 ml or, if possible, 4 ml of blood and store it in a deep freezer. But in a higher center, that is possible. But it is better to send directly to a lab for whole exome sequencing. So at least the sequencing is done, and if genetic diagnosis is there and the child expires, then the sample is no longer available. So if based on the genetic variant that is come, you can always go for antenatal diagnosis in the next pregnancy. There are parents whose first child have expired and they really don't have a genetic diagnosis in the first child, because we were expecting to do it after a few weeks, but the child expired and the samples were not collected. So it has happened more than once for by patients. So even if not affordable, I try to store it from my side. If affordable, I try to send it. Currently, it's 4,000 to 5,000 if you allow the labs to compete. So most of them are sending it immediately, planning for the antenatal testing in the second pregnancy. That is like one thing in management.
And
I
sir,
think
earlier
Thank you.
we used to admit these children because, but now we try to avoid the admission as much as
Yeah.
possible. Only if somebody is having severe laryngeal complication, say, then probably
Yeah.
we admit for the multidisciplinary management or some other systemic complication. Otherwise, most of the time it is outpatient department
Yeah.
management.
Yeah, antibiotics you would leave it to the pediatricians, or would you suggest?
Sir, we do it ourselves if we see, because we explain it to them very clearly that our main aim is to prevent secondary infection. And whenever you see any sign of secondary infection, if it is limited, topical antibiotics can be used. And if it is systemic, then you have to come and we'll advise the systemic oral. Uh,
Is it better that so not many are working of us here are working in tertiary centers? So
yes.
what do you think is the best option for a person who is working in a not so tertiary hospital when they have a baby like this in the NICU?
So the antibiotics, regarding
No,
antibiotics, you
no,
say?
regarding the management of the child
Oh,
in a
ne-
resource poor, not a resource poor setting, but not a tertiary center like AIMS or other places. Maybe a good corporate hospital or a good center or any medical colleges. Not all of them are very equipped. Most of them are. But what would you suggest? I
Sir,
mean,
even
with
in
your
neonatal
experience
stage,
of seeing such
yes.
babies.
So even in neonate stage, parents they really insist for admission in NICU, but we ask them and advise them repeatedly not to get admitted. So that is not a requirement. NICU is not a requirement until unless there is severe infection or severe involvement to suggest. In most of the cases, OPD basis management we do, sir, and supportive management. So I think that can be done even at the tertiary level, but as Dr. Irene said, the samples can be collected for genetic analysis.
Any of you are involved in any projects of this epidemiology in Bangalore? I think Manipal Hospital they have an epidemiologist bulosa project. So anything? Do you have anything in the horizon to offer? Are you aware of anything?
Sir, earlier,
Uh,
sorry, Irene, you were
uh,
saying.
no, I thought there was a project on diacerin. I'm not sure if you are
Right.
involved. Yeah.
So topical diacerin PGINMs are involved in epidermolysis bullosa simplex patient as a topical anti-inflammatory drug, sir. And before that we were also doing some project on stem cell therapy, but that is still under the research. It has not come out as a patient management. And latanoprost also we have tried, sir.
Yeah, many years ago I used to hear about phenytoin. So that is totally out, or
No,
I mean that
that's
was
out. It
just
doesn't
myth.
seem to work very well. Some people
Yeah.
have tried IV gentamicin also, but most of the therapies have not had great luck with based on the.
I think we have. Uh, dwell too much on this. So then now we have this newborn baby who is present, who has multiple large and medium-sized melanocytic nevi, and the child had generalized seizures on second day. So tell us what you think of. I think Dr. Iron, you want to take on
Yeah.
this?
Yes, sir. So, as a child with melanocytic nevi, I think the most important factor would be number as far as systemic features are concerned. So, currently, we are not worried about the local management at present from the way it looks. So, sir, and this child, first thing I would do is do a brief neurological assessment, and if I possible, get assessed by a full neurological assessment by a pediatrician. So, and since it is more than two, I would plan imaging of the CNS. not too late, but maybe after the first 1 or 2 months, if the child
Even
remains
if the
symptomatic.
seizures are not there, this child,
Yes,
of
sir.
course,
Yes,
seizures.
sir.
If the
Because
seizures are not there, also, even then, would you plan
yes,
for an MRI?
yes. Sir, I have two indications. Generally, we follow two indications. One is that the child is symptomatic, then directly an imaging. But if the child has like significant number of lesions, generally anything more than one is considered significant. So the problem with the CNS involvement and the ocular involvement is that the manifestation can be like 2 years later. But the best time to image is under 6 months. So we know when to, if we know that there is CNS melanocytosis, the neurologist or the pediatrician can follow much more closely. Otherwise, we can be relatively reassured because by 6 months, myelination happens. But neonate, again, MRI is a very difficult thing and sedation is again risky for them. So I wouldn't do it in the first month, but generally most of I think the new pediatric neurologist I work with does it in the second to third month. They plan it carefully, do a full evaluation because mostly sedation is required. So then we image the CNS once, and if nothing is there, great. We limit the follow up to the skin, and if something is there, based on the severity, they schedule a neurological follow up.
Thank you. Dr. Ramkumar,
Yeah.
how would you explain the prognosis for this child? I mean,
Sir,
if
as Dr. Irene said, any child more than one lesion, you should suspect what is called CMN syndrome, and MRI is a must. It can be done after the second month. With contrast, MRI we have to do only under anesthesia. We have to counsel the patients. We have to counsel the pediatrician also. And any child, I mean, within 6 months, but even third month also, it is possible because the reason is there may be neurocutaneous melanosis in 20% of them, especially the brain and skull and spine also included. MRI with contrast we should do. And if there is neurocutaneous melanosis, it's not that there may not be any acute problem. Many of the child may develop autism, hyperactive disease later on. So the mental development may be delayed, mental milestones may be affected. So it's very important for us them to inform the parents that it's not the acute issues, it is not hydrocephalus or melanoma, etc. Second thing, if you get a clear CNS, it is clear CNS, it is clear in MRI, you can ensure them that the child will not develop, most likely will not develop a melanoma within the central nervous system. Because melanoma can develop anywhere also, though the chance is only less than 2%. Second one is about this skin lesion. We have to always remember that there are two benign conditions which can come in the skin also. What is called benign proliferative nodule and diffuse neuroid proliferation. So not all that nodular things which come in the skin are all malignancy. So any nodular growth in the skin has to be biopsied. So we have to inform the patients to watch whether development of any nodule or induration and report to us, and they should be biopsied. It can be simple benign proliferative nodule, or it can be neurocrystoma also, or it can be a neuroid proliferation also. Not that it's not that all proliferations are only malignancy. And the chances are less than 2%, especially if the size of the lesion is more than 60%, then there can be as high a chance of some 10%. Otherwise, it is just 1 or 2% only. So three things are important: the seizures and acute conditions. Second, the skin counseling about this development of the nodules and malignancy. Third one is the development, the behavioral development of the child. If neurocutaneous melanosis is there, you should ask for the neurologist to follow up or the pediatrician to follow up the mental milestones.
okay, before I go on to the next slide, just can I ask you how many cases of NCM would each one of you have seen in your career? I think Ram
Last,
Kumar,
because I'm working in the tertiary
last 20
hospitals.
years, 25
Yeah,
years, how many would have seen?
at least 30%, 40% of these children, they have got neurocutaneous melanosis. At least 30 to 40%. For at least, I remember some last 3-4 years, some 15, 20 scans, at least 6 of them had 6 neurocutaneous melanosis. Yeah.
Yeah. Okay. And what about you?
I saw a patient today itself, a patient of giant.
Okay.
I remembered you when I saw giant congenital melanocytic nevi with multiple satellite nodule. and involvement of brain. And we were just reviewing the literature, and we really wanted to help the patient. So we were seeing that tremetinib, which is a MAC inhibitor, sir, has been tried in giant congenital melanocytic nevi to reduce the burden. So we were discussing it with pediatric oncology team because they are using this drug frequently, but they also said that there is no end point to it, how long you want to give the medicine, and they are
Can you
not.
just repeat the drug name again for our
Tremetinib,
viewers?
tremetinib, sir.
Okay. Okay.
Tremetinib, TRE, I think, like imatinib, it is tremetinib, uh,
Okay.
MAC inhibitor.
Okay. Okay.
Ma'am, do you also agree with the timing of the scan? I'm just interested to
And
know
so
what
that
the.
we do within first 6 months, not exactly at 2 months, but we try to do it within. But melanocytic proliferating nodule, Ram sir, I think they are so common. So most of the time we just reassure them. And if we see any signs of in IGDVL, we have reported also, sir, a young girl with a melanoma on large congenital melanocytic nevi, then we definitely take it for biopsy.
I think, can I go to the next case? That is basically, this is a very common problem. I think it's a very common problem. It's a 10-day-old neonate with the erythema or the diaper area involving the buttocks, sparing the inguinal and the gluteal creases, no satellite lesions. So, diagnosis and differentials. Dr. Nita, would you like to take that, or Dr. Ram, anybody?
Sir, I would think of irritant contact dermatitis because
Okay.
of the young age, and there is a constant environment of moistness, and there is constant occlusion because of the diaper wearing. So that would be the first thought.
Yeah.
But as we can see, the folds are spared and the groin area is spared, then the infections will also come into the. Sometimes we see streptococci, if I'm not wrong, causing causing gluteal infection. So that also we want to rule out. And a condition called infantile granuloma gluteum, if the parents are using topical steroid for prolonged situation. So these are the lines of thought, sir.
Okay. Anybody wants to
What
make
is
any
the age
additional
of the
comment?
child? What is the age of the child?
This is a neonate. We're not think
Four
neonates.
weeks, 4 weeks, 5 weeks.
10 day
Oh,
old.
oh, okay, okay. Usually within the
Uh,
first 3 weeks, it could be irritant diaper dermatitis, but generally the first 3 weeks we have to be careful, as Dr. Neetu said, whether something else is going on. But in this child also it is irritant hyperdermatitis most likely. Irritant, maybe the child may have stools, etc., diarrhea or some other issues, feeding problem or something. That is why they will come with this kind of erosions. And after 3 weeks, sometimes you can get what is called erosive perianal eruption. That is also very common. Erosive perianal eruption. It will continue like that. So that they are more important, and I don't think they are all very deep. The photograph, it looks like very
Very
you know
superficial lesions.
yeah. So erosive perianal eruption is another condition we should think about. Child more than 3 weeks, 4 weeks, 5 weeks, etc., especially due to diarrhea, and then due to
Okay.
that
Dr.
inflammation.
Iron, if the creases are involved, what are the differential diagnosis? If the
Yes,
creases were
if
involved.
the crease is involved, I would think of most commonly I would think of candidiasis, sir. And if it is a short lasting eruption, and I look for the maceration, the satellite lesions, and all that. Later, if it is a persistent crease eruption, I would think of seborrheic dermatitis, infantile psoriasis at a later stage. If there are papules and nodules, I would look at other sites to rule out LCH, Langhans cell histiocytosis. Those are like rarer entities. But this
Okay.
one, the perianal involvement is first, and then the convexity sparing other creases. That seems very typical of irritant dermatitis without any candidal infection. I
So,
would
what are,
consider for streptococci, as both the other panelists mentioned.
okay, great. And just tell me what you will tell the parents on how to prevent it. So, because that is,
Yeah, sir.
no, 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 let us, 1 second. First, how would you treat this child? What is
Yes.
your line of
Uh,
management?
So in this case, there are erosions and there is significant erythema. I probably would add a topical agent against gram positives, mostly mupirocin. But maybe 1 or 2 days only it will rapidly heal in case of perianal streptococcal cellulitis. But main thing would be I would check what diaper they are using. So whichever, whether they prefer cloth or diaper, I prefer super absorbent diapers because I feel it's more practical to keep it dry. So I would just say that the stool contact is the one that they have to avoid. So I'll teach the family to check that the stool should not be left there for any period of time. So whatever measures, either with the cloth or super absorbent diapers, whatever they have to follow, they have to manage changing frequently. And generally, I advised Vaseline or sometimes a zinc paste as a plain bland barrier. So
More
a
for
clean,
preventive. We're
most for
talking about the
preventive.
prevention.
Yeah. In
Uh,
the start also, when they apply fusidic acid, I would say start with the non-eroded areas. I would start with the barrier cream because zinc helps to heal pretty rapidly. So and clean with water, and sometimes they use wipes, and some of the wipes are not even alcoholic wipes. So that has happened. So I would check the wipes, make sure they wipe with water and pat it dry, apply a barrier cream, apply mupirocin for a few days, and change regularly.
my favorite topical agent of choice is here. I don't know how many of you would agree with me on that. Is gentian violet. So, can you have your inputs on? Because I always, if it's infected, maybe institute an antibiotic or just gentian violet. And just 2 days, I'll ask them to avoid a diaper, and then, of course, go for the same thing. Once I feel the epithelialization has taken place, then I shift to a topical. So, what do you do? Um, your inputs on this management,
Sir, one thing
Dr. Ram.
here the question is not about treating the infection. The question is treating about the irritant aspect. And perianal
Yeah.
streptococcal dermatitis, we can very clearly recognize severe pain will be there. And in this age group, a little bit older age group only you will get. Not in this age group. It's not that common last we read in our books. This is a very common thing in pediatric practice. Since I am sitting day in and out in a pediatric hospital for years, this is a very, very common practice. A child admitted immediately within 5 days you will have this kind of problem, because one thing is, we most of the diapers do not work for more than 3 hours. Our people do not change the diapers, so it is overnight.
Yeah.
The child may have an intercurrent infection like fever, etc. That area becomes more inflamed. So first to treat the irritant aspect, like what Irene said, cleanse, gentle cleansing without wet wipes. Try to use, do not use hot water, I mean not very warm water. Cleanse it, dry it, then apply a good amount of Vaseline or liquid paraffin mix, and maybe to add an topical antibiotic. Diaper care is more important rather than choosing the what is the right antibiotic here and all. That is my idea, because it is all secondary thing only, because a very clear erosion is
Okay, thank you. I think we'll go on to the case 7, which is basically a neonate who presents with. I don't know if you can appreciate it. Can you appreciate the annular plaque on the preauricular region?
Yes, sir.
I
Yeah.
hope the audience also can appreciate. And even the axilla, you have an annular, slightly infiltrated plaque. So, the 2 weeks of age, and the mother has a history of autoimmune disease, but was asymptomatic during pregnancy. So, how will you go about this child, uh, Dr. Aaron?
Yes, sir. So, this is an annular plaque with autoimmune. I think the most important diagnosis is congenital lupus. So, most important thing is an ECG, and I would get a rhythm strip, get it reviewed by a cardiologist. I'm looking for block. I would simultaneously look for thrombocytopenia and LFT derangements. And if possible, if the mother already has a full ANA immunoblot available, that would be great. Otherwise, I would send it because I want to know what antibody she has. So, because if it is raw, then I would think of heart block. Otherwise, if it is U1 as an RNP, then the cardiac involvement is unlikely. So, but then ECG once, because usually at the time of birth, if the heart block has to happen, it has already happened. So, monitoring is not required, but it's generally skin examination, platelet count, LFT, and a ECG. That is the usual extent of my investigations.
Yeah, and most importantly, you have to reassure also that these lesions is usually it is due to the transfer of the maternal antibodies and the skin lesions. Any red flags here, Dr. Ram?
Sir, see, it's not that always the mother may not have a problem. Mother may be normal. Mother may have even Sjogren's syndrome. So once you suspect a neonatal lupus, or I mean in the NLE, because it's a variant of subcutaneous, I mean subacute lupus only. The first thing is get an echocardiogram because the pediatric cardiologist will be available near your place. Ask him to do an echocardiogram. Second thing is check for raw antibody in the mother. These two are most important. So then, depending upon these two, you decide and first child, second child, the risk will be more. Suppose it's a first child. Second child, the risk may be more. Then you have to plan, before once they get pregnant or all that. So most of the time they won't have any problem. But some later on, the mother who is normal in one of my situations, mother who was initially normal later on developed an autoimmune disease. So it's very tricky thing, and it can come with variable manifestations in the OPD. The child may be absolutely normal looking, but we should not, I mean, we are not the right persons. Again, I'm saying to say whether the child is normal. The child, a pediatrician should be always in the loop. That's what I want to emphasize.
Okay. Dr. Neetu, would you like to any extra points or inputs apart from Dr. Ram and Dr. Irene has said?
No, sir, I agree. So we recently saw a case of neonatal Ellie. It was I think within 1 month the child presented with the characteristic lesion, and I got very scared. Called the pediatrician immediately, but they were not as worried as we were, because as
Yeah.
Dr. Irene said, the cardiac blocks happen very early in the or at the birth they are detected, or in utero gestation. So they said just do the routine investigations and just follow up, and within I think that by next month or next to next month the lesion subsided spontaneously and child grew up healthy, sir.
Okay.
Yeah.
I
I
think
agree with
we'll.
ma'am. Pediatricians are very unconcerned.
Yes.
Okay. Okay. Now we go on to the collidon baby. All of you can very clearly say you can see the ectropion, eclabion. The bands also, its photograph is a little cut over there. So, what are the differential diagnosis? Of course, um, what are the differential diagnoses you would consider here? Or, I mean, very too early to consider differential diagnosis here. But anyway, for our viewers, can you just tell us what are the things which a collidon baby can progress to? Dr. Neetu?
Yes, sir. So we know circuloidian baby may have multiple outcome, and we have to differentiate it from the only worrisome thing which can happen at this age is harlequin ichthyosis, since the manifestation is completely different of a mild collodion baby. So we just counsel the patient that in 10% of the cases it may be self-healing colloidal baby, but otherwise most of the time majority of them will go to autosomal recessive congenital ichthyosis. Many of them may also have syndromic ichthyosis, so that evaluation is essential. And bathing suit ichthyosis, which is a type of AR ichthyosis, is also possible. And sometimes we see neutral lipid storage disease or Gaucher's disease as a manifestation, Sjogren Larsen syndrome. So this group of disorder is also possible. So we have to see the systemic involvement. So there are multiple possible outcome, but majority are mild.
Um, Dr. Ram, what are the skin care essentials you would impress upon in this particular child? I mean, what are the things which you will write down in your consultation record when you
See,
see a
usually
colloidal baby?
usually neonatologists they call us whenever they see the child. The most important things we have to tell them is high humidity, like 80% or 70%, 80% high humidity in the incubator. That is very important, and general care of the child. And often you have to check whether breathing is normal, whether breathing child is struggling with breathing, and then you have to look on the eyes, whether child is able to close the eye, and then ear and the fingers, whether sometimes it will be like a cocoon, the entire fingers will be encased in a cocoon like thing. and toes also, and sometimes the child may not be even able to move also. Harlequin child means I have given acitretin in a Harlequin child. Normally in a collodion baby, I don't try to give any systemic medications immediately. I wait and watch, and I ask them general care is most important. High general care is most important. Treatment of infections, treatment of fluid balance, and high humidity care. These are all more. And use paraffin liquid. Do not use proprietary preparations. Many of them may irritate the child also. Use simple paraffin Vaseline mix. And after 2 weeks, usually you will come to know what is sometimes you'll see dramatic improvement after 2 weeks. Later on, you can, as Dr. Neetu said, most of them will turn out to be autosomal recessive, and very rarely you may get something like congenital ichthyosis and other conditions. The Gaucher's disease and all you can pick up in the neonate itself, and you'll have that collodion baby will have a shiny, different look, and yellowish look, like you can find it out, and at least you can do a peripheral blood smear if and liver enzymes. That all most of the time in neonatology they have got a routine also. They will do follow it all of them.
Thank you. Thank you. I
And
think we'll
eye
go
care.
on to, yeah, anybody wants to comment on there?
So I think that's it.
Yeah.
One thing is to teach the ASVIT EB to meet the full NICU team, like including the nursing staff, and teach them how to keep the emollients infection free. So I either use the small parachute bottles of with one per application with sterile gloves or cleaned hands, or we use it with a disposable scoop, Vaseline with disposable scoop that will be separately brought for the baby. So that is one thing that we enforce immediately. Rest I think is covered.
Okay. I think we'll go on to the next case because I think we are almost we already shot up this thing. So, but Dr. Priya, we have two more cases. What do you think?
It's okay, sir. I think
Okay.
everybody is there only. All are
Okay.
interested.
Okay. So now we go into the spatial capillary malformation and neonate presents with unilateral port vein stain involving the forehead, eyelid, and cheek with extension to the to one limb. Of course, the diagnosis is, I don't think it's a problem. So not all these will take up. So what are the important differential diagnoses at birth? Dr. Aaron.
Sir, so clinically, what is visible is a capillary malformation. Like it's extensive, it's segmental in two different sites. So first, I would just examine closely and see if it is just a capillary malformation. Is there any indicator that it is complex? So maybe an area of pallor, warmth, pulsations in any area, bruit, and I would get a radiologist do an extensive ultrasound so that we can get a preliminary idea without sedation and see if there is any obvious feature of a complex malformation like a venous component or an arteriovenous component. Second thing that I'm worried about will be the eye involvement and the CNS involvement. So the same day ophthalmologist intraocular pressure measurement because that requires immediate intervention. And as far as imaging goes, it's mostly since the fontanelle is open, we'll go for a neuro ultrasound first, see if there are any gross anomalies, and reserve the imaging for later. But this child, I think, definitely requires a neuroimaging, detailed neuroimaging later. But it is in this case, unlike in melanocytosis, we want to do that after 6 months or preferably after 1 year. If symptoms are there early, otherwise postpone it is what I would do.
Okay.
Then syndromes also, but then at this point in time, like syndromes with multiple capillary multiple malformations, but that I would keep for a later date, not in the immediate assessment.
Okay. Does all facial capillary malformation require systemic evaluation?
No, sir. In this, yeah, ma'am, continue.
Yeah, please proceed.
Yeah, Dr. Ram.
So, um,
No, later,
sir,
please
Ram, sir,
proceed.
please proceed. Yeah, maybe I'll complete the thought that in this child, the neurological imaging, the forehead upper eyelid is involved. So that is the same vascular source embryologically as the internal carotid. I mean, which will go to the brain as well. So embryologically, that area is related to the CNS vasculature. So that is why in this child, I would keep a CNS imaging somewhere high up in the list.
Dr. Rakesh, can you show the photograph?
Yeah.
The photograph.
Have you also
Please.
noticed that?
Yeah. Please draw a line from the outer canthus, eye canthus, no, from the midline. You take from outer canthus to the upper end of the helix, ear helix. Yeah, you draw
Yeah.
imaginary line, continue it up to midline, continue that line up to midline. So that, yeah, that, see, this is what was found out by
Like this, huh?
Yeah.
Yeah. You draw up to the midline here also, towards medial also. Yeah. Yes, excellent. So any child which has got a Portwine stain above that, you should investigate for Sturge-Weber syndrome. Please remember, it has got nothing to do with trigeminal category, because this Portwine stain is nothing called, it's due to a mutation called GNAQ mutation, guanine nucleotide Q mutation, Q polypeptide mutation. This was for, it's called GNAQ mutation. It has got, Happel has written multiple times. It has got nothing to do with the trigeminal,
Yes.
category. So if you see a Portwine stain, this was found by a person called Welchly. You would read 2013. It was published in the NEGM. So the present teaching is, you find a Portwine stain above that imaginary line from the outer canthus to the upper helix, that area, you should do a imaging within the first 3 to 6 months. Sometimes imaging you should do only MRI, because CT scan will pick up only a calcification. Sometimes imaging may be normal. If any doubt in the child condition, you have to repeat it also. Otherwise, the child will grow for develop seizures. I understand that ultrasound, you can easily do ultrasound in a neonate, but that requires a specialized person very good in
Yeah.
ultrasound. So
Yes.
you may always miss it. Here, please, I have seen children for whom newborn, they have done, even before this concept was there in 2008, 9 and all, newborn scan was normal, in the CT scan was not. After 3 years, child developed fits, seizures. So this is a very tricky, difficult conditions. So it's our duty, even second, third month also you can do, to tell them whether they are doing it or not is a different thing, because the child, and second thing, eye examination. Very important. You can mix that glaucoma in the eye also. These two should be done. You should think it that it could be this Sturge-Weber syndrome. This is the concept for the last 10 years or so. That's what I want to tell you. Not to, say, undermine what you have all brought it out. Just to, give a new information.
Yeah. Excellent. Thank you so much. I think we'll go on to the next case. 1 second. So this is a newborn who presents with multiple cutaneous. I'm sure all of you have come across a newborn who presents with multiple cutaneous hemangiomas within the first weeks of life. Now, what will be your approach to this child be, Dr. Neeta?
Sir, again, if the number, so they have defined this cutoff of five, number of
Yeah.
five. So if the number is more than five, they call is diffuse neonatal hemangiomatosis, and baseline screening for systemic involvement is required, which include involvement of liver, because hepatic hemangioma is a close association, and because of the involvement of liver, consumptive hypothyroidism can be seen. So thyroid parameters should be done, thyroid hormone level, and evaluation of otherwise general functions, whether CNS, all the clinical evaluation for rest of the functions are required, sir.
So these are the clinical red flags. I've just enumerated it. Clinical red flags for when you suspect diffuse neonatal hemangiomatoses. That is 5 or more, hepatomegaly, tachypnea, poor feeding or failure to thrive, and signs of heart failure. So which are the
Right.
organs to screen, Dr. Irene?
So I usually do an ultrasound of the liver and a thyroid function test. Other organs are less common. I don't routinely screen, but I was reading up and I found that I should be looking at the lung as well. Clinical features of congestive cardiac failure and lung, and if there are CNS anomalies, a CNS screen as well. But I think ultrasound liver to screen the liver, abdomen, watching for GI bleed, and TFT, that should be adequate.
And says, like you have mentioned, just clinical evaluation of hepatomegaly may sometime there are reports that have saved the life of children because you can do urgent intervention. So hepatomegaly is an important sign.
I think that's it. One second, one second, one second. Before I sign off, I just have this thing. I didn't put it earlier because I saw this child. I think more than 15 years ago. The child did not survive. I believe. I just remember just having a consultation. It was, I think I saw it from Pariyar. Raji sir might remember. This was more than 15, I think more than 15 to 18 years. I remember with this child with this butterfly rash, but this thing, you can see the peripheral. And this was like, I don't know if you could label as aplasia cutis, which is usually on the scalp. But if you can see the demarcation of the skin,
Yeah, skin.
the ulceration, I think, I don't know if there's the muscles visible or just a membrane covering it. You can see the peripheral hypertrichosis. So, I mean, I don't ask me anything other than this. I don't remember anything. This was more than the 17, 18 years ago.
I was
But
going to
this,
ask about neural tube defects.
no, no, don't ask me anything. So this baby has been etched in my mind for too long. I don't have a diagnosis. I just have a giant congenital melanocytic nevi with aplasia cutis. So if you were given seeing this child in your neonatology department, what would you put your notes as? Each one of
So,
you.
sir, you should do, there may be tethering also, neurological, but the skin lesion looks like diffuse neuroid proliferation or neurocrystoma. The skin lesion, I
What
don't
is
know,
that?
I will take a biopsy. This skin lesion,
Uh,
this
no,
pendulous
clinically, what did
stigma,
you put it as? Because,
diffuse neuroid, it's a congenital melanocytic nevus, but it is
Nevus, okay.
covering the midline. So you should always look for tethering. This, tethering, spinal dysraphism. You should always look for, and very easily you can do MRI and find it out, and immediately see. You can ask the neurosurgeon to relieve the tethering. Child will do wonderfully. And but the skin one I was talking about could be diffuse neuroid proliferation. It is not benign proliferative nodule. Could be, but I may be wrong. So you can do a biopsy for the skin thing, and also you should check for neurological issues also. I mean, here you should do brain as well as spine also. MRI, definitely MRI imaging you have to do, because that
oh,
coloring is there very
okay,
clear. But
Dr. Neetu Bari, in one
melanocytic is
sentence,
not a,
the clinical description and the diagnosis.
So because of that peripheral hyperpigmentation and hypertrichosis, the giant CMN appears, but as you said, the morphology is very unusual. So I would maybe investigate further, look for, as Ramsar said, spinal and brain involvement. But I don't have a name for it. I'll have to read what Ramsar is saying. Neurocrystoma.
diffuse
Thank
neuroid
you.
proliferation.
Yes, sir.
That is something new to me. I've not heard.
Sir, you had shared this before, so I had looked up in literature, but I couldn't find any reports like that. But the midline lesion, the aplasia cutis, everything, I that way I reached till neural tube defects. So
Yeah, definitely. Melanocytic nevus is not a very risky. Only hemangioma
yeah,
is the risky thing. Or
and
you should have
aplasia,
hair around the perianal, 2 centimeters outside the anus. They are all the risky things. And
yeah,
this is less risky, but still, in this case, we should not miss it. Anyway, you are going to do spine and scalp for
brain.
I mean, MRI for the melanocytic nevus. So why don't you,
Why not look for that?
alert the, radiologist? I think.
Okay, so I think we have come to end of this very extensive, fruitful, excellent discussion. I should say, we really have real experts amongst us, and thank you so much for your valuable inputs. I'm sure the audience has gained a lot from this discussions, and maybe even I a lot of things I heard for the first time. So. I think it would definitely have been a wonderful experience for the our young dermatologists and even older people like us. Thank you so much. And Dr. Priya, I'm very sorry for overshooting the time. And I would like to thank the IDVL um, and the online academy for giving us this opportunity to showcase neonatal dermatology to our wonderful delegates who have joined us. I think we had a very good attendance here. Thank you so much. Thank you so much. Especially, I would like to place a record the work done by the online dermatology, Dr. Priya and Dr. Nimita, who has curated the program so well, and of course the PST and the whole EC, Dr. David, Dr. Joanne, Dr. Bobby, Lasida, everybody Dr. Firoz, who has been wonderful all the time. Thank you so much, and thank you for the opportunity.
Excellent session, sir. Sir, we have a couple of audience questions waiting to be answered.
Oh, yeah,
One
sorry, I
question
forgot about
directed to
that.
Dr. Irene.
Yeah. I saw the
Ma'am,
question to
yes,
enlist
sir.
the labs.
Yeah.
Since I think we are all professionals here, I can. So I used to send to specifically MedGenome. It's not the lab that is particularly cheap, but the fact that they are competitors. So usually, if we are sending genetic testing regularly, I tell them that the patient can only afford this much. And usually, sometimes the patients also manage to bargain and bully them into a lower price. It's not and for hospitals, even if the private practitioners they charge more, sometimes if you link it to a hospital, they do give offers to individual hospitals based on the numbers. So that one option is to link it to a consultant in the hospital and see if they will give any offers just for the testing purpose, but retain the patient with you. And I think Carcinos is coming up now. I think what Dr. Vinod Skaria is involved in that. And Lalpath also has things. The thing is that these three labs, I think one more name I forget now. All I have tried out at least once, and they give good reports, and the support from the genetics team is also good. Not had a major bad experience from any, but even for government institutes, they do approach you and say, from this institute, we will give at a low price. So it as low as 7,000, in very occasional cases, 5,000. So it's not a regular thing. It's different. Their set rate is different, but generally we negotiate with them. And sometimes the patients are also very smart and they negotiate a price. So that's it.
There is one question directed to Dr. Ram regarding the dose of S-citratin in harlequin ichthyosis.
Go up to 1 milligram, madam. Normally, in lamellar ichthyosis, 1 milligram works. Usually, that dose only we will start. Sometimes we have to go higher up than. Usually, 1 milligram per kg is the dose in lamellar ichthyosis. Same thing we follow in harlequin. But I have not given many cases. I gave in 2 cases, and both of them, patient did not survive also. Not because of this medication, because of other issues. So because they're asking about the newborn harlequin. That's what when I mentioned that, yeah.
So that brings us to the end of today's very enriching academic discussion. On behalf of IIDVL Kerala Online Academy Cell, I would like to extend my deepest gratitude to Dr. David Pudukkadan, President of IIDVL Kerala, and our Honorable Secretary, Dr. Joanne Felicita Sampson, for their unwavering support and guidance, and that made this webinar possible. I would like to extend a special thanks to Priya Pratap ma'am, our chairperson of IIDVL Kerala Online Academy, who's actually visionary leadership brought us together virtually today. And I would like to profoundly appreciate our moderator, Dr. Rakesh SV, for expertly steering the panel discussion with poise and insight. And my heartfelt thanks go to the brilliant panelists, Dr. Ramkumar Ramamurthy, Dr. Neetu Pari, and Dr. Irene Matthews, for sharing their invaluable expertise on neonatal dermatosis and enriching our understanding with all those practical pearls. Thank you to all our moderators and panelists. And we are equally grateful to all members of Online Academy Cell for their tireless efforts behind the scenes. Finally, a big thank you to our dynamic audience for your active participation. And thank you all once again. Very good night to each and everyone.
Are we forgetting the photograph?
Yes, sir. So before we end, could everyone please switch on their camera so that we can have a quick group screenshot? Priya ma'am?
Yes, I am here. Thank you, Rakesh sir, and all the panelists for the wonderful discussion. Thank you very much.
Thank
We
you,
owe you a
ma'am, for
lot
inviting me. Yeah.
for your
It was
time
very
and
exciting.
contribution.
Rakesh sir, as always.
Thank you so much, ma'am. Thank you, Nimita. Thank you,
Thank
Rakesh.
you.
Thank you all.
Ram sir. Thank you,
Have a
Irene.
good night. Thank you all. Thank you all once again.
Thank you, everyone. Bye. Good night.
Thank you.
Bye.